But having said that, we've just completed a turn-away survey at King's. We did it for the first time this year. And it clearly demonstrates that people come to the GUM clinic after often going to their GP and asking to be screened for an STI or having a particular test or getting a contraceptive service. And the GP actually saying, sorry, we can't see you, go to the STI clinic, go to the GUM clinic. So there's a bigger piece of work here of not just looking at how the GUM clinic is performing, but looking at the wider system and working with our general practitioner colleagues and making sure that they have the skills to do the screening and to look at how we work with voluntary sector organizations as well. So we create a whole system which is equipped to do screening and signposting for people. And that's what we do.
Because I think that some people, that they don't feel well, they're thinking of the bigger picture. And they think, no, I don't have HIV, and I don't have the bigger illnesses. But chlamydia, for example, is something very important to be tested as quick as possible so that you can get treatment straight away. And a lot of people don't do that. And I think that in there is where the GPs are failing, because they don't say to them, well, look, if I cannot test you here, there are clinics that they can see you, and they can see you in confidence. They don't do that. And the people wait and wait and wait for weeks, and they wait in a state of desperation almost, until somebody else tells them what they can do. And I think that publicity, or discreet publicity, is something that maybe perhaps we can increase.
Yeah. I agree. And
especially for chlamydia.
Especially when you have the online service, that there's no reason why people who are seen in a GP practice should not be referred to an online service. London Sexual Health, and you can get your kit by the following morning, and you can know your diagnosis within 3 or 4 days.
That is publicity, so that they know what they can do and do
exactly.
easily.
Exactly. Yeah.
Thank you very much.
Sure.
Thank you very much.
My question is sort of related in that I have 2 questions actually. My first question is about access to services, and as we've been discussing, the e-services are really convenient. Having used it, I have friends that use it. It's really, really fantastic way of accessing this healthcare. Although I have just Googled, STI clinic or STI test in Southwark, and it still directs you to SH24. And if you go through that process, it then tells you that Southwark is no longer a borough that you can access this free test. Yeah. And I have had friends that then said to me, why has Southwark Council cut that service? But we need to have some way of alerting people to the fact that this service is now changed. And so my question is, one, about how you communicated that change, but also I've been one of those people that have gone to the GP to ask for STI tests and been told that you need to go to the borough centre or whatever. And actually, it's really inconvenient for lots of people to go to these centres during the hours that they operate. And how are we? What about those people that do work full time or that do have difficulty going during normal office hours? How are they able to access services out of hours? And what's being done to increase that?
So there are many options, and first of all, it comes back to the point that was raised earlier about the need for us to continue to mobilise and to educate our general practitioners for them to know that the London service is ready and available, and it should be routing people there. Now, if a person thinks that they're symptomatic, then they will be prioritised to get an appointment as quickly as possible. If they're asymptomatic and they want to be seen out of hours, then both Kings as well as Guy's have services on the weekends, on Saturday mornings. Now, they've been playing around and innovating with those because those are expensive to keep open, and they have to look at the cost-benefit of that. But across London, there are network clinics that will allow you to be seen over the weekend. For most STIs, they're not life-threatening, and you can wait until Monday morning. Or you can order your test kit on Saturday, and it will be there with you on Monday morning. So there's an issue here of just reassuring people that actually, if you think you may be at risk, order your test kit now, and it will come as quickly as possible. The only exception to that is if you've had unprotected sex with somebody who's HIV positive, and you require post-exposure prophylaxis, in which case you can go to any A&E unit in London, and you can get your PEP. So there are provisions for being seen out of hours, Clearly, the best route now is to go online and to get your kit and to do that, and we have to do some launching on that.
Yeah, I think if you could feedback though that it'd be great
Yes.
if SH24 did actually put the link through to the right service now because it's so convenient.
I will check that because I did my mystery shopping from Civic as well, and
Yeah.
it took me straight to the London sexual health site. So I think that there may be something going on in terms of how people are routed.
I have just tried tonight and
You
it's
just
the
tried
same.
it. So yeah, so I will ask the team to follow up on that.
My second question is about LGBT access to sexual health, and there is currently an LGBT survey going on in Southwark. So I'd be interested to know, how you plan to respond to the findings from that, because a lot of the focus of the survey was around access to healthcare.
Yeah.
And I know as a young gay man in Southwark that has been to to Borough Street, that I was told that I should use PrEP, and that was then something that I asked them if it was available, and I was told I had to go and buy it myself online. I think subsequently the NHS England has done a trial, so I'd be interested to know, do you know how many Southwark residents have actually been able to access that trial, and how many have, whether or not we're actually promoting that as well as something that is now available in this borough.
So by current estimates, over 500 men in the borough have accessed PrEP via the trial. Recognizing that the trial has spaces for initially 10,000 people, and then I say we because I'm on the board for the National PrEP trial, have increased the number of slots available to 13,000. And currently there are 9,000 people across the country who are on PrEP via the trial, and we're expecting the 13,000 ceiling to be reached by March of next year. So the question then becomes, what happens to PrEP provision when we reach the maximum ceiling in the PrEP trial? And it's a much bigger discussion with NHS England and the Department of Health about what their plans are for commissioning PrEP. Your first question, however, was on LGBT health and the LGBT questionnaire, and I'm really pleased that there is a survey being done to assess the needs of LGBT people in the borough. As I said, Lambeth and Southwark have the highest concentration of LGBT communities in Western Europe. Between our two boroughs, we have the greatest numbers of LGBT individuals in Western Europe. And it means that we need to be looking not only at their sexual health, but we need to be looking at issues of substance abuse. So whether it's alcohol or tobacco, we know that there are higher rates of smoking and drinking in LGBT communities. Use of recreational drugs. Mental health issues are also important as well to the LGBT community. And then around that, a number of the social and economic factors, including poverty. There's an assumption that the pink pound is a rich one, and that once you're gay, all of a sudden, or lesbian, or transgender, that you are more affluent than the rest of the population. In fact, that's not the case. And so there are lots of LGBT people who are living in poverty, who are homeless, and as a result of that, entering into lots of high-risk behaviors, including drug use and selling sex for money. So a survey such as this will help us to understand what our needs are in the borough at the moment, and how do we ensure that we have a holistic approach to addressing those needs. So it's not just about providing online STI testing at all, and it's about ensuring that there's good mental health services available, good drug services available, including alcohol, and helping people to address social isolation, which is also another big issue in the community, which is now just coming out as well. So loneliness and isolation, a huge issue for LGBT people. So even in a borough such as ours, there's a large community as a problem.
I think that point is really good, and I think maybe that's something that we should consider is when the LGBT survey is actually concluded and the analysis is done on it, it'd be something that would be worth bringing back to this committee for us to actually look at the plethora of issues that are there and the many different services that are there to try and respond. So,
and if I could just say, do bear in mind that there should be no surprises on this, because we've been doing surveys of LGBT communities over the last 2 decades, 3 decades. I think the question that we should be held accountable to ask is, what are we doing about these findings? Because I can guarantee you're going to find that black and minority, ethnic, gay and bisexual men and LGBT people are going to have poorer outcomes. I can guarantee that you're going to find young working class white MSM who are grappling with drugs and who are grappling with high rates of STIs and HIV. And I can guarantee you're going to find issues of social isolation among older LGBT people, people who didn't expect to survive the HIV epidemic, who are now living in poverty and in isolation because they've lost their friends, they didn't have a job through their adult lives, and they're now poor and they're not relying on state support. We've known these stories for many years. So the question, I think, becomes not just having the data from the survey, but to say what will really change now as a result of this, and how can SUBEC take the lead on it. And I'd be very keen to work to lead on that from the public team to help us to do something better.
Thank you very much.
Yeah, thank you.
Quick follow-up from
Just
Maria.
very brief, rather than to leave it at the end, I need to remark that I think the most important thing is information and education, and I think that we have to start at the school age. Very, very important to educate them from the beginning. Now the other thing is virtual clinics.
Yes.
How do they think? I think it is a great idea of having pilot clinics after office hours. How are they working? Do you have anything to add to that?
So I can't give you any information there because that's at an early stage of development.
Yeah.
But as you know, telemedicine and medicine via your phone is now increasing in popularity. GPs are now doing online consultations over your mobile phone. There are a range of apps which are available that allow physicians to have an interaction with the patient, to look at a lesion using the camera, and to provide a diagnosis. And so there is a thinking about whether or not that can be applied in the sexual health setting and what that would look like. So there's certainly some piloting to be done there. And Lambeth and SUBEC have been at the forefront of innovations in sexual health services in the country. In the country. So, let me be unequivocal about this. If there's anything new happening in sexual health and HIV, it usually comes from Lambeth and SUBEC. And so, moving into an area where we're looking at telemedicine, where we're looking at mobile telephony to think about sexual health services is exciting. And I'd like to see us do that. And to your first point on information and education, I couldn't agree with you more, and that's why I'm really pleased that the government has decided to focus on providing sexual and relationships educations in schools. But the detail is going to be in the policy and what actually gets implemented. And we look forward to seeing more from the government shortly. The problem with the monies that we have in the public health grant is that they're so limited that we have to focus on providing services. And there's very little money available for us to do anything in terms of the information and education space. And that's why I think in general we need to continue to advocate for the public health grant to not be cut any further, and for us to move from tackling downstream problems of people coming in with infections to helping to promote resilience, better health and well-being, dealing with drug issues because and mental health issues, which is driving high-risk behaviors, and giving more education and information. That is where we need to be. But the system doesn't allow us at this time.
A lot of things are connected.
Yeah.
But also, if you do not educate everybody, when the children get sexual education in schools, go back home, talk to the parents, and the parents says, what? What are you talking about? They have no idea, no clue what they are talking about.
Yeah.
So I think it has to be both. It has to be balanced education.
Okay.
Thank you so much.
Great.
Thank you.
Thank you. Peter, Alice, then Hamira.
Thanks. Two quite quick ones, and it may just be that it's a clarification point. One was great that there's, particularly in the King's example, there's more access happening online. That in the case of King's, kind of reduced hours is still seeing kind of increased numbers. I just wondered, is there potentially any kind of hidden issue there in terms of, like, say, different ethnic groups or ages, kind of access and services, particularly with the kind of reduced hours? So has there been kind of profiling of the kind of group they're using, the different services and the different time periods?
Absolutely, there is. So we have been very, very mindful of this when we established the services, because we know from previous studies that when you introduce a digital service, you tend to disenfranchise a certain sector of the population. So people who don't have mobile phones, who don't have access to a computer, etc. So as we've rolled out the SH24 as well as the London e-service, we've built upon the lessons of both. For the London e-service, early data suggests that two groups that we need to be particularly mindful of are young people who may feel less confident in having a test kit delivered to their home and for that package to be opened by their parents. For Black and minority Asian ethnic individuals who may receive a test kit but for whatever reason don't complete the process and send the kit back in. And so we're not seeing a difference in requesting a kit, but we're seeing a difference in sending back in their kit. And part of that is just about how do we continue to ensure that instructions are clear in multiple languages and so forth. But part of it is also changing behaviors. And when people are just used to rocking up to Borough Street at 7 o'clock and waiting in line until 10, sometimes it's hard to change that behavior because they think that's the way it should be done. But we are mindful of this and we're checking it through the governance board.
And then the second question was just on the details that you set out. I kind of understood in the kind of Gaia's context that it seems that they're doing, we'll follow their trialing, or they trialed reduced opening hours and did like kind of surveying after it. I was just a little bit more unclear with the King's case, isn't it? They did surveying before. I was a bit confused if they'd done surveying afterwards as well.
Yes, so it just, there are different ways you can evaluate the service. The way Guy's did it is a sort of academic way, which is you do something for a certain period of time, you do pre and post questionnaires, and then you're able to evaluate it. What King's has done is to do the sort of pre-work and then implemented a model, and then afterwards they are doing their evaluation just to see how this works. And I think I included some data there on large clinic times open and so forth. So they are very pleased that as a result of their evaluation that they've done, so it wasn't as rigorous as the GALs, but they have done an in-service evaluation, that although they've reduced time overall, they have expanded access to physicians, and through that they're seeing more STIs, dealing with patients at peak hours, and have better patient satisfaction as well. So just different ways of evaluating the service.
Thanks.
Thank you very much. Alice?
Yeah, they're actually slightly related. So one was just in terms of the kind of the completion and accurate, like, you know, actually doing a test on your own is quite different from being in a clinic and having it done. And just if there's any, if you are at home and you want extra guidance, is there a number you can call? Is there like a, you know, while you're in the process of using the kit, is there like ongoing support for that? And is there any analysis around, I don't know, accuracy as well as completion of the test?
So there's analysis on kits that are distributed and then kits that are returned. There is a helpline, but I don't have any data on how many people have called, etc. Interestingly, when it's been piloted for SH24 as well as the London e-service, the most difficult thing is to actually do a pinprick and to express the blood from your finger into a small vial. And I did the whole thing, so I did that just to see how hard that would be. And for somebody who's medical and who's done lots of injections over my life, you just think, oh, will people really do this? But people actually do it, and the instructions are very clear, and when you do it, it's actually very easy to do. So we have a number of markers that we track, including complaints, as well as people may express their dissatisfaction by defacing the kit or by sending in messages to the service. So we collect all of that, and that becomes rich, almost qualitative data as well to let us know how people are responding. But overall, as I said, because Lambeth and Southwark had been among the last tranche of boroughs to come into the system was up and running and functioning. So we really haven't had any negative complaints at all from our residents. And there isn't an issue for access. And we've not yet maximized, there's no cap that we're placing on Lambeth and Southwark residents in accessing the service, which is a good thing at the moment. Some boroughs are because their sexual health funding is not less.
And just a quick question, which might be one more from us in terms of process. Quite a lot of the data in the pilots, we haven't got the results from yet, they're collating it. So it's just in terms of time frame and whether that's something that can be sent back to the committee so that we can see.
Sure, absolutely, absolutely. And I'm sure at some stage you will invite Evelyn and Koto in our public health role to speak to you. So that might be an opportunity for us to put some data in front of her as well. So we could do that too.
Thank you very much. Last question, unless anybody else wants to, goes to the mirror again.
Sorry. And it's half been answered because Peter asked a good part of the question. I just want to flip that question in the opposite direction. So, how are you measuring the impact of the online services to vulnerable demographics? So what I mean by that is not so much that they're not necessarily returning their kits, but actually those that are completely turned off from using the service that may have used the service in person before, but now no longer qualify to necessarily be seen face to face, is one question. I've got a second, sorry.
Okay, so we have, when you complete your online testing, you have to give in a certain amount of demographic data as well as your postcode of residence. So in the online service, you will be able to look at your age distribution, your ethnicity distribution, your sexuality distribution by area of postcode. Now we can compare that with the information that we would have received from GUM clinics to see if they're significantly different.
Okay.
And if there are areas that we miss. So that sort of analysis is what we do. So we can look at, within a jurisdiction, are there people who are systematically disenfranchised?
And when's a good moment to kind of start to have a look at that data and see whether there is?
Well, as I said, we've been tracking that since day one. I would suggest that we go for a 6-month report. So
Yeah.
that would be in October, November. And then, of course, the 1-year report after Southwark has joined the program.
Yeah.
So a 6-month report will be coming out in time in November, December. So there's all kind of
Brilliant. And then secondly, in terms of the online services that are offered, so there was, I may have also mystery shopped it, sort of. And on there, there was a number of things that they will test for, but there's also a number of things that they don't necessarily test for. And I'm not medical, so I don't know what you can test for. But things like human papillomavirus, I don't know if there is now a test for that. And then a number of other elements as well that weren't on the list. Is there a plan to introduce those as part of the online testing as well, or is it not possible?
No, there isn't a plan, in part because the services which are offered on online testing services would be what you would routinely get in a clinic
Right.
if you went in as an asymptomatic person. And you would not routinely be tested for HPV if you went in for a GUM clinic visit, unless you complained of having genital warts or you were having colon pap smear.
Right.
Okay, so that's the only reason why you'd have it. We wouldn't routinely take an HPV swab either on a woman or on a man. Now there is one test that is a bit controversial that colleagues have been saying, why are we not doing this routinely? And this is a test for trichomonas.
Yeah.
And I'm not sure if you know about the epidemiology of trichomonas, but it tends to be seen more in women of colour than white women. And in men, it tends to be asymptomatic. So women are doubly disadvantaged. They have higher levels if you're a minority woman, and you're less likely to be diagnosed if you're a man. So therefore, the transmission continues within the community. And we have some of the highest rates of trichomonas in South London among our diverse communities. And by offering only an online STI screening services that tests for syphilis, gonorrhea, HIV, and chlamydia, and not for trichomonas, it means that we may be unintentionally worsening the trichomonas epidemic because we're not assessing for it.
And you're giving reassurance to the others.
So there are research studies being done now to see whether or not the epidemiology of trichomonas is getting worse, who are we missing, and if we need to do anything within GUM clinics to address that. And there's also a project which is being done to see whether or not they can introduce trichomonas as part of the routine screening in the online service as well. That's the only one that I know of that we're thinking of tweaking the model with.
Okay. Thank you.
If there are no more questions, thank you very much, Kevin.
Right. All right. Thank you.
Thank you.
Okay, we now move to item 7, which was the work plan. We need to redraft the cabinet member interviews because we were meant to have 2 tonight, and we only have 1, so that needs to be redrafted and sent out again. and we need an extra meeting to fit it in, so you and I will do that with Shelley, and then we'll bring it back to the committee.
Yeah.
I did also ask for the chairs of the commissions to submit a very high level thing of what they're doing, their work plans. I've got one from Barry Hargrove. Helen, do you want to speak to yours now?
Yes, that's absolutely fine.
Yeah, go for it.
So the Housing and Environment Commission is meeting for the first time this Wednesday, which is great to get it off the ground. The kind of two substantial items that we've decided to look at are firstly to take a report on empty homes. So that there's an initial report which has been published now, which is coming to the Commission on Wednesday. So obviously it's the first meeting, so we'll be doing a bit of getting to know one another, but we also wanted to take a substantial report so that we could really kick things off. I think we'll see where we get with that, but we may then want a further report at one of the subsequent meetings, just in case there are any recommendations that come out of the initial discussion with officers around that. And then the other item that we are going to be looking at is community energy, which obviously kind of straddles both housing and environment, to look at the commitment that the council has to support community energy projects to help people reduce their bills. And it also builds on some of the work that a previous Deputy Cabinet Member, James Caldwell, did too. We are just having some conversations about how it fits in with what the Cabinet Member is doing around that, because it will essentially be almost kind of pre-scrutiny work, but there is agreement from Cabinet members that it would be useful for scrutiny to be involved in that process. And I think what we're going to look to do at the second meeting, therefore, is to pull together a kind of round table where we invite experts, representatives from TRAs who might be interested, and really kind of convene a really good discussion around how we might best take forward that council commitment. The other thing just to note is, because I'm on OSC, one of the things, whilst there's not a kind of formal link between the commissions and OSC, what I thought it would be useful to have on the agenda is an opportunity for the commission members to identify questions that they might want to put to the relevant cabinet members, of which there are essentially three, I guess, who are relevant, actually four, sorry, who are relevant to the work. So it may be that that I come to OSC in the future and I might have my own personal questions, but there might be some questions that the commission members have said that they would like to put to cabinet members. I don't know how that will work in terms of process, but we can follow that up. And finally, at the final meeting of this year, we are keen to take a report on how the process of moving the repairs service in-house, which obviously now happens, how that's going. It will just be a kind of initial, how's it been going in the first few months. May be something the Commission wants to look at again in the future.
Wonderful.
That's basically the plan.
Thank you for that update. I've got a written update from Barry Hargrove, which I'll circulate, but I'll read out. Barry Hargrove is the chair of the Healthy Communities Scrutiny Commission. They are looking at health inequalities. At their first meeting, they had a presentation from the Environment and Social Regeneration Officers setting out what the council is doing in terms of leisure and parks to promote healthy activity. Their next meeting is going to focus on getting a better understanding of the baselines as to what exactly are healthy inequalities and the key areas, and to that end to further make progress across the landscape of that topic. But I'll punt this out so you've got it. And John and Leanne will update us on the next meeting, if that's okay with everyone, and then everybody has a record of what's going on in the four commissions. If there's no other business...
Can I just check, we don't yet have dates for the other commissions, do we?
Not as far as I'm aware.
No, that's certainly true, but I'm hoping I'll be able to set dates out in a couple of days. So, we're looking next month for the first meeting.
I think sooner the better, really, to make sure you
Yes.
feel diaries.
Okay, that's the meeting ended. Thank you very much and good night.
Yeah, sorry about it.